We're going to see a presentation from Dr. Mark Summeray. He's been in the pharmaceutical and medical devices and biotech industries in the U.S. and Europe for the last 23 years. Currently, he is the Chief Medical Officer at Amolyt Pharma. So let's see what Dr. Summeray has to say.
Good afternoon, everybody. My name is Mark Summeray. I'm the Chief Medical Officer at Amolyt Pharmaceuticals. It's a pleasure to be with you today, and thank you to the Hypoparathyroidism Association for the opportunity to present an update on enebopartide, our progress in development, and our phase 3 Calypso trial. So for those of you that may not be familiar with Amolyt, we are a biotech company that is focused on developing new treatments for rare endocrine and related diseases. And our goal through the development of these new treatments is to transform the lives of patients suffering from these conditions. This slide shows you an overview of our pipeline. If you look at the top of the slide, you see enebopartide for hypoparathyroidism. That's obviously going to be the focus of my presentation to you this afternoon. But just to point out that we also have some other products in development, one for acromegaly, which is also a rare endocrine disorder, and further back in development, still early on in the laboratory, we're working on some new treatments for hyperparathyroidism, the opposite issue to hypo, so where there is an overproduction of parathyroid hormone, which can happen in relation to a tumor or in relation to other cancers. And these two areas, acromegaly and hyperparathyroidism and humoral hypercalcemia of malignancy, are both also areas that Amolyt is focused on. But as I mentioned, today we're going to talk about enebopartide, which is an agonist at the PTH1 receptor. So this is the structure of the peptide. A peptide is simply a sequence of amino acids. And you're probably all familiar with a protein. A protein molecule is simply a much longer sequence of amino acids. A peptide is really just a short protein. And enebopartide, which is also sometimes called AZP3601, is a sequence of amino acids, 36 amino acids long. And it's actually synthesized by chemical synthesis in the laboratory. And it's very similar in structure to naturally occurring parathyroid hormone and a related hormone called parathyroid hormone-related peptide. And the scientists that designed this molecule did so by taking certain sequences of amino acids from both of these naturally occurring hormones and joining them together, and then making a few changes to the sequence, just substituting some amino acids for others. And these amino acid substitutions are all so-called naturally occurring amino acids. And in the process of doing this, they've generated a peptide which will bind to the parathyroid hormone receptor in a very special way. And so in order to explain this, we've created a video which we're going to show you now.
Hypoparathyroidism is a rare endocrine disease characterized by parathyroid hormone, PTH, deficiency. Without PTH, normal blood calcium levels cannot be maintained because the kidneys are unable to reabsorb calcium, the intestine is unable to absorb dietary calcium, and bone turnover stops. Low blood calcium levels cause a variety of recurring symptoms. On average, most patients experience 16 symptoms per day, lasting 14 to 16 hours, leading to a reduced quality of life. Simply treating with PTH 1 to 34 or 1 to 84 peptide injections is not optimal because the effect is too short. PTH binding to the PTH1 receptor triggers the binding and activation of a G protein, initiating the biological effect. Upon G protein release, the receptor assumes a different conformation known as R0. Because PTH binds weakly to R0, it is rapidly released from the receptor, ending signaling. Consequently, PTH action lasts only as long as its short blood half-life and cannot provide 24-hour symptom control. Prolonging PTH in the bloodstream may allow sustained normalization of serum calcium levels and symptom control, but has been shown to cause significant bone loss and may not normalize elevated urinary calcium in all patients. Like PTH, the investigational drug enebopartide is a peptide made of natural amino acids that binds to the PTH1 receptor and has a short blood half-life. However, enebopartide is uniquely designed to bind tightly to the R0 conformation of the PTH1 receptor. As a result, when the G protein is released, enebopartide remains bound, allowing multiple rounds of G protein binding and signaling, thus producing a long effect. This prolonged activation of R0 by enebopartide is designed to restore normal calcium reabsorption and vitamin D production by the kidneys, which may allow continuous maintenance of blood calcium without supplementation or bone loss. Through its unique mechanism, enebopartide is designed to maintain normal blood calcium for a full 24 hours to better control symptoms and improve quality of life.
So just to explain a little further, having seen the video, of course, the most important thing is to understand how enebopartide actually behaves in the clinic. In other words, how it behaves in humans when we measure its effects. And this slide is showing you two things. First of all, on the left side, how the enebopartide, how the peptide has a very short residence time in the blood. It has a short half-life. And on the left side, you can see that after different doses are injected just once, there is a very rapid clearance of the peptide from the bloodstream, so that after just 2 hours, it's no longer possible to detect the presence of enebopartide. And then the graph in the middle, as well as the graph on the right, shows you the effect of a single injection in the middle and multiple injections on the right of enebopartide on the calcium levels in the blood. You see the middle graph shows after a single injection of enebopartide, there is a rise in calcium levels which lasts for at least 24 hours at the higher doses. And the same observations are made after multiple dosing once a day of enebopartide in the graph on the right side. Now, the data I just showed you were generated in healthy volunteers, healthy human subjects, but of course it's even more relevant to look at data in patients with hypoparathyroidism. And the graphs you're looking at here show the results of our phase 2 study with respect to a reduction in the dose of active vitamin D or calcitriol after patients were started on enebopartide. Across the bottom axis, you can see time from day 1 to day 84. And the results have been divided into two graphs because we had two separate cohorts of patients. On the left side, you can see after 14 days, the average dose of active vitamin D came down dramatically, almost to zero, after enebopartide had been administered for 14 days. And the same observation on the right side in the second cohort of patients. And over longer treatment periods, out to the end of the 84-day treatment period for the study, the dose of calcitriol was reduced to 0 in almost all of the patients. There was only one patient in each cohort that was still taking calcitriol. And we also made the same observation for calcium supplements. So as you are all no doubt aware, calcium supplements are given to patients with hypoparathyroidism in order to try to maintain calcium levels in the blood that can make sure that we avoid the symptoms that are such a distressing part of this condition. Once enebopartide treatment has been started, you can see, in a similar fashion to vitamin D, we see a rapid reduction in the average dose of oral calcium, such that by the time we get to the end of the 84-day treatment period, almost all of the patients are taking doses of oral calcium supplements well underneath that horizontal orange dashed line, which is the dose of oral calcium that represents the difference between just a supplement dose and what's considered to be a therapeutic dose, which is 500 milligrams or more. So what we can see from these data, that once enebopartide treatment has been started, patients are able to discontinue the supplements very quickly. And of course, it's also important to see that enebopartide treatment is capable of allowing the blood calcium levels to be controlled within the desirable range. And in this phase 2 study, the desirable range was given to the doctors as between 7.8 and 9 milligrams per deciliter, the range that's shown between the orange dashed lines there. And in both cohorts of patients on treatment with enebopartide, the blood calcium levels were maintained successfully within this range, while at the same time the supplements were withdrawn. Another important goal of treatment for hyperparathyroidism patients is to normalize the amount of calcium that's present in the urine, because we know that higher levels of calcium in the urine than normal results in injury to the kidneys over many years as a result of kidney stones or deposition of calcium salts in the kidney itself. So we're very happy to see that on treatment with enebopartide in this phase 2 study, we saw a rapid reduction in urinary calcium, so that after just 14 days, the average urinary calcium level is below the upper limit of normal. So we've normalized urinary calcium, and you can see that the levels continue to decrease in both cohorts of patients through to the end of the study. And this is a very important observation because it's such an important goal of treatment to normalize urinary calcium in patients with hyperparathyroidism. We also focus on bone safety. And what we're measuring and showing you in this slide are chemicals or markers that we can assess in the blood that reflect how much bone turnover there is. And turnover means how much new bone is being formed versus how much old bone is being broken down. And normally, in patients or individuals who do not have hyperparathyroidism, we always have some degree of bone turnover happening where old bone is broken down and replaced by new bone. But in the absence of parathyroid hormone in hypoparathyroidism, this process tends to decrease dramatically so that old bone accumulates and it isn't broken down and replaced by new bone. So once we see treatment here with enebopartide, what we're looking at is an increase in these markers in the blood, which reflect both bone formation as well as bone breakdown or resorption. And the encouraging element here is that the magnitude or the degree of rise in both of these biomarkers is quite similar over the 84 days of treatment. And that means that we're seeing a balanced increase in turnover. In other words, we're seeing a rise in both bone formation and bone resorption, but one is not dramatically greater than the other. and that's a more physiological situation, and suggests that over longer treatment with eneboparatide, we wouldn't expect to see bone loss. We would actually expect to see some bone turnover, but a fairly stable situation with respect to bone. And we think this is an important observation, particularly in patients who may be postmenopausal females, because of the risk in postmenopausal females of a decrease in bone mass, a condition that sometimes is usually referred to as osteoporosis. And so therefore, we think that bone safety with eneboparatide is an important element or feature of this peptide. So to summarize the data that I've just shown you in patients, we've seen a good safety profile with eneboparatide administration. We have not seen any serious adverse events reported with treatment. And none of the adverse events that were reported in our clinical studies were of severe intensity or resulted in discontinuation of the drug. We also have seen the ability to maintain normal levels or target levels of blood calcium while withdrawing the supplements, which is very encouraging. We also saw normalization of the amount of calcium present in the urine and an effect of eneboparatide on bone, which is suggestive of a restoration of a balanced or physiological bone turnover situation. So with all of that said, we have the data we need to move into a phase 3 study or a pivotal trial, which has just started, actually, including centers in the United States. And this is the design of the phase 3 study. The study has defined different endpoints, which are methods of assessment of the efficacy of eneboparatide in treating patients with hyperparathyroidism. The primary or the most important endpoint is the proportion of patients who achieve control of blood calcium levels within the normal range, while at the same time achieving independence from their supplements. But in addition, we also have some secondary endpoints, which are also very important. The first one is normalization of the 24-hour urinary calcium levels in patients who start the study with elevated levels of calcium in the urine. And then we have a number of secondary endpoints which are focused on the assessment of the impact of treatment with respect to the symptoms of the disease and impact of the condition on quality of life. And then in addition, we have some safety endpoints which include bone safety. For the reasons that I explained just before, we think that bone safety is a very important component of treatment of this condition. And we're going to be measuring the biomarkers or the chemicals that I mentioned in the previous slide. But in addition, we're going to do DEXA scanning, which is a way of assessing bone mass over time. So how much bone mass the patients have on treatment, as well as an additional imaging method which uses CT scanning to measure bone quality. And you can see at the bottom there the design of the study. We're going to enroll enough patients so that we can randomize 165 patients in a 2-to-1 fashion, meaning twice as many patients will be randomly allocated to receive eneboparatide as placebo. And then there's a 24-week period during which patients will be either treated with eneboparatide or placebo. And then at the end of the 24-week period, anybody that was on placebo will be crossed over to receive eneboparatide, so that all patients will be on the drug for the next 28 weeks to the end of the study protocol. And we do plan to have an extension study beyond the end of this Calypso trial, which would keep patients on treatment, and patients who are doing well and benefiting, as we hope they will be able to stay on the drug probably for at least another 2 years, or indeed, if the drug is ultimately approved, until that happens. Here you can see the distribution of clinical sites. We have a number of centers in the United States. You can see those represented on the map, as well as mostly in Western Europe and also in Australia. So we actually have 63 sites participating in the study, and 18 of those are present in the US. We also have 3 sites in Canada. Here is a list of the sites, as well as the principal investigators. On the right-hand side there, you can see in bold. You probably recognize many of the doctors that are listed here. These are physicians who are participating in the study and supervising the patients together with the other staff at the sites. And I mentioned also we have 3 sites in Canada as well. You can see these listed here. So I'd like to conclude with just a few remarks. First of all, as you've seen, enebopartide is showing some promising data from the early phase clinical trials. The data that we have suggests that enebopartide has the potential to control blood calcium levels while at the same time allowing patients to discontinue their vitamin D and calcium supplementation. And we've seen that enebopartide treatment is associated with a rapid normalization of the amount of calcium that's present in the urine, as well as having a balanced or neutral or physiological effect on bone. And as I've just shown you, we have a phase 3 study, which we also call a pivotal study, that is underway and enrolling patients in the United States and Canada. And we expect to finish the enrollment for the study in the first half of next year. So with all of that said, I'm now going to be available to participate in a live Q&A session and be very happy to address any questions you may have. Thank you very much.
All right. Thank you, Dr. Summeray. And questions in the room first?
Okay, I have one online that says, how long is the washout period for PTH replacement, such as coming off of Forteo or not para for this study?
3 months.
Is there any limit on calcium or calcitriol dosing or changes leading up to the screening visit?
No, we just have some minimum requirements, meaning that you need to be taking over a certain amount, more than a gram of calcium supplements per day, and also over a certain amount of vitamin D supplementations, but there isn't a maximum.
And does enebopartide have any impact on lowering phosphorus?
Yes, it does. Yes, so we've seen the effect of enebopartide on phosphorus in particular in the first few hours after dosing. So yes, we would expect to see some potentially beneficial effects on the levels of phosphorus in the blood.
Okay. Michelle, do you have one before? Okay. Got another one for you.
Hi. Oh, is there someone else talking?
Go ahead.
Hi. I was wondering if you've looked in any of your studies so far, if you've looked at how activity level is accommodated with your medication for high activity levels, such as gym workouts or days at an amusement park. Is additional calcium required with your drug?
So at this point, we've only done some relatively limited assessments of the impact of the drug on quality of life, using a very general questionnaire that captures some symptoms that reflect ability to function from a physical point of view, as well as how patients feel. And that early data is encouraging. As part of the Calypso study, which I've been talking about, we have a much more detailed assessment of all of the impacts of the disease on the patients in terms of signs and symptoms and quality of life. But to specifically address that part of your question about is it expected to have an impact on the ability to be physically active and requirements for taking calcium supplements, we certainly would expect to see an improvement in terms of how dependent you are on having calcium supplements available. We expect that requirement to come down quite substantially once on the drug. And we would also expect to see an improvement in general sense of well-being ability to function, concentrate, the brain fog issue, which is often a problem, we would expect to improve, if not completely disappear. And we'll be looking to generate, or to collect, I should say, the evidence that would support that expectation. So certainly things that I think would enable people to exercise and enjoy activities to a greater extent.
Okay, thank you. Michelle?
Are there any patients with hypopara fatigue issues doing better on your drug?
Well, it's very early days. So all I can say is that anecdotally, we're hearing some encouraging commentary from some of the physicians who have started treating patients in the study. But I can't really give you any specifics so far because obviously we have to collect all of the data and analyze it. But I would say so far so good.
And then I have several people asking basically the same question. Can you do a little more explaining of why there needs to be a washout period for those that are on Natpara or Forteo?
Yeah, so the reason for that, there's probably two reasons. First one is that we need to be able to only to isolate the effect of enebopartide on the ability to control calcium levels in the blood, as well as withdraw the supplements, which hopefully will no longer be necessary once on the drug, and the effect of the drug on other things like the amount of calcium in the urine. So what we can't have is a background of other drugs that may also be influencing those things that we wish to measure that will reflect the action of enebopartide. So we need to sort of remove any of those potential confounding influences on those really important measurements that we want to make, so we can very clearly see the impact of the drug. Apart from, there shouldn't be anything else to confuse the situation. And the other reason is that we want people to be in a very stable situation during the run-in period, so that their calcium levels are well controlled and their background supplements are not being adjusted all the time. So they're in a very sort of good place from a sort of stable situation before we start the treatment. Because then what we observe after starting the treatment is obviously only due to the treatment. It's not due to anything that's changing in the background. So obviously having other drugs that might be being administered would be a problem in that respect as well, potentially. So these are the reasons.
Okay, Dr. Kohlmeyer?
Yes, thank you. That was fantastic. I have a question and then just a couple comments, because there's many of you that are in trials, and our U.S. site investigators are here. And we know that placebo doesn't work with hypopara, as we've shown in past 3%. So even though it's blinded, after a while, if you're in a trial, if you're on parathyroid hormone. And so both with TransCon and AZP, my experience is amazing. I mean, patients talk about improved quality of life within days. Where are my fibromyalgia symptoms? I mean, what we've heard for the last 2 days, but for us, it's so rewarding. So I wanted to share that. One important thing for the AZP trial is to be off of thiazide for a month. And so that, as a provider, worries me sometimes, because I know your urine calcium is going to go up, but it's important. And then my question is the dietary calcium intake that, you have to fill out the diaries and all that. How detailed are we going to have that information in this trial? Because it's so important to know how much, whether people have lactose intolerant or celiac, because as their calcium supplements go down, I don't want them on no calcium, and they know to stay on their D3, but they're almost all off active D. So I think that dietary calcium, do you know how detailed and how much information we're going to get in that regard?
Well, so first of all, I agree. it's really rather artificial to think only of calcium supplementation when there's such an important contribution from the diet. And as we know, dietary intake can vary. So it is being collected. I can't say, I have to be honest, about the level of detail that's been collected in the diary, electronic diary entry that we're using in this particular study. So I'd have to come back to you on that, Dr. Kohlmeier, but at least we are collecting some dietary calcium information.
Thank you.
Michelle?
Is there a chart that explains the similarities and differences between TransCon PTH and Calypso?
Just to clarify the question, is the question about the studies or about the drugs?
I think it from the way it looks, it's about the drug. Like, what's the difference between PTH and PTH-RP?
Oh, no, that's another question. So let me try and answer what I think the question is. So TransCon PTH is PTH 1 to 34. It's the important part of the PTH molecule that's been coupled to another molecule that gives the whole thing a very long half-life. So the approach is really to modify how long PTH is present after it's dosed, so that you can get a much more even control of calcium levels over a 24-hour period between doses. And of course, it makes a lot of sense, because we know that if you don't do that, if you don't make that modification, PTH itself, or PTH 1 to 34 after it's injected, it doesn't stay around for very long. It's only a few hours. So this is really the basis and the logic behind TransCon PTH. In the case of enebopartide, it's just a different way of addressing the issue. Instead of modifying the half-life, in other words, taking PTH and making it last an awfully long time in the blood, there's been some changes made to the individual building blocks that make up the PTH molecule. And these changes were done in a way to change the way that the enebopartide binds to the receptor. The receptor is the way that the peptide achieves its effect. It binds to this protein on the surface of the cells, and then its effect results after that. And so what we've done with enebopartide is change the nature of that binding between the drug and the receptor, and it results in a very long effect. So instead of changing the half-life of the drug, we've changed the result of the binding of the drug. So now, whether or not that turns out to be an advantageous approach, we will have to wait and see. But as you would have seen from the slides I presented, the data that we've generated so far certainly are consistent with what we were expecting to see. And I would say we have every reason to be optimistic about ultimately what we will demonstrate, which is what we hope is good control of calcium, ability to come off the supplements, particularly the vitamin D, and also bring down the calcium supplements, even if they're not totally eliminated, and control calcium and normalize urinary calcium in patients, because the high levels of calcium in the urine over a long time are a problem for the kidneys. So we think, we're seeing so far signs that enebopartide is capable of doing all of those things to a very good degree.
Very good, thank you. And Bob, did you have somebody else?
So I'm wondering, and maybe you said this and I didn't process it, but if you're predicting improvement in kidney function, or actually reversal, so like from CKD3 to CKD2 or better, or?
Well, that would be nice. I think, so that remains to be seen. One thing that we can measure very quickly is the amount of calcium in the urine. So that's point number one. Point number two is that it's generally accepted that high levels of calcium in the urine are not a good thing. And it's generally understood that the reason for that is because the calcium can cause problems related to stones that can form in the urine, and that in turn causes problems with the kidneys, as well as the calcium being deposited in the tissue of the kidney, and that's toxic to the kidneys over a long time. So if you think about the logic, it would certainly be a reasonable expectation that over a long period of time, if you're able to normalize the levels of calcium in the urine, so bring them down quite substantially over a long period of time, you would certainly expect that any injury that would have occurred would no longer occur. In other words, we would hope to see stabilization. Would there be a possibility of improvement? Perhaps. But it would certainly take a long time for us to see that. And, we have to follow people on the drug for many years, and large enough numbers of those people actually, before we would start to generate the data that would suggest that perhaps we are having not only a beneficial effect on the calcium, not only stabilizing perhaps the kidney function, but maybe even doing what you just suggested, which is improving people in terms of the category of renal function measured by their filtration rate, seeing it improve. It's a possibility, but it'll be a long time before we see that.
Okay, thank you. One more question?
I have one online that says, how would you reverse this molecule's effect if there were a need to, i.e. if a patient was starting to go hyper?
Well, the good thing about the drug is that it has a short half-life. That means that if you stop dosing it, then you will see that it's gone very quickly. Now, of course, as I already explained, when you dose it, it has a long effect. And by that, I mean, after a single dose, the effect lasts for 24 hours or more, maybe up to 48 hours. So in this situation where the calcium's too high, the most likely thing would be to simply decrease the dose. I think the important point to make here is that each patient's treatment with the drug is very carefully adjusted so that as the supplements are withdrawn and the patients are started on the drug, there's a titration, an adjustment of dose over time so that whatever is the right dose for that patient, it's achieved over time according to the result, which is really the monitoring of the blood calcium levels. And this is done by the doctors who are very closely monitoring what's happening with the calcium and adjusting the dose accordingly. In the unlikely event, and of course it can happen, that calcium goes too high, it's always possible to lower the dose. And we would expect to see the result of that lowering relatively quickly in the next 2 or 3 days. So it ought to be a matter of adjustment of dose according to calcium response. And it's a relatively quick relationship between the two.
All right, one more.
Hi, can you speak more to the dose change specifically? Why you guys chose to go up and down by 10 instead of 5? Thank you.
Right. Yep. Well, I suppose the simple answer to that one is that each drug is different in terms of the relationship between any particular dose and the effect that you're trying to achieve. So that dose response relationship is different if we compare enebopartide with other PTH type or like drugs. So it's not surprising, therefore, that the amount of the drug that you start at, which in the case of enebopartide is a 20 microgram dose, that starting dose would be different from another PTH drug. And then the adjustments, the magnitude or the size of the adjustments are also different, up and down by 10. So that's the first point. The second point is the reason that we do that is because we've obviously very carefully studied that relationship both in the laboratory and then in healthy subjects. And we've made predictions about what we should expect to see in terms of the relationship between dose and response. And then, as I mentioned, we've done a phase 2 study, and we looked at it there as well, because phase 2 is when you really fine tune whether or not you've got the right dosing for people. The good thing is, as I already mentioned, you can adjust the dose to suit the patient specifically. And of course, it's also true that you could adjust the dose by 5 if you needed to. It's not something that we always anticipate might be needed before we get into a phase 3 study. We would never dictate to any physician what they can and can't do ultimately in the best interest of the patient. So if a change of 5 is the right thing for the patient, then I think that's what the doctors will do.
Okay, well, thank you, Dr. Summeray. It was a wonderful presentation today. Thank you.
Thanks very much.